reason we are not able to understand or grab, because whosoever becomes a doctor is not ordinary. Am I right? So all of us are extraordinary. But why we suffer in studying after so many years of studying in post graduation? The reason is that, especially if you talk about anesthesia, physiology, pharmacology, okay, anatomy, then pathophysiology, okay, the clinical sign symptoms, then the treatment strategies, okay. Actually, we have all studies these things in bits and pieces. When we are in final year MBBS, we are not studying actually physiology. But when you are studying anesthesia, suddenly they will be asking you what is oxygen hemoglobin dissociation curve. Am I right?
Yes, sir.
So till the time, so for liver, for example, uh, if we just try to see, so we should be knowing what are the sign and symptoms related to liver. Okay, if we just try to think about it. So if you start with symptom, so what do you think in the liver problem? What are the usual symptoms?
The patient will be having bleeding, as
Bleeding, okay,
portal hypertension,
hypotension,
ascites.
symptoms. Okay, so,
Okay.
ascites may be symptom as well, but usually it is sign. Okay, what else? You are missing the
Mm.
smallest of the symptoms. You are jumping towards serious symptoms.
Loss of appetite.
Loss of appetite is called as anorexia. Okay, so anorexia.
Pruritus.
Then nausea, vomiting. Okay,
Pruritus.
pruritus. Pruritus because of bile salts.
Obstructive. Yeah. Obstructive
Okay,
disease.
what else? Abdominal pain.
Mm. Yes.
Okay, then you are missing. After that, you have not label. Just a second. Please. Yes, unmute yourself, Nashida. Please.
Yes, sir.
Yes, you have not mentioned the most common. Usually, the first thing when we talk about liver, the first thing is jaundice. Okay, so when we are
Jaundice.
compiling, we are missing the simplest of the thing. Okay, so we talked about this nausea and vomiting. Okay,
Mm.
so it may be associated with, if it is associated with this portal hypertension. So what will be the symptom then?
Bleeding.
Hema- Hematemesis.
Hematemesis. Yes. Bleeding
Okay.
because of the varices.
Yes. Okay. So if it is going, it is not coming up, this bleeding going down, then it will be
Hematochezia.
hematochezia, or actually hematochezia is usually fresh blood. So it will be melena, not
Melena. Okay.
hematochezia. Okay. Usually it will be melena. Okay. So
Okay.
when this melena or hematemesis occur, then what will happen? Anemia. So the
Mm.
things are correlated with each other. But if you understand with the simplicity, it will be easier for you. You will not forget. Okay. So what
Mm.
else can be the symptom? Symptom. Think about symptom. What about change in color of
Oh,
stool
stools. Yeah.
or
And urine.
urine? Urine. Okay. So if you remember
Yes.
this with jaundice, you will not miss it. Okay. So now if you uh, correlate them, usually some things will be related to the synthetic function. Okay.
Mm.
Something will be related to the you can say because of some cellular destruction. Okay. And something will be related to, for example, obstruction. Okay. Something will be related to coagulation problem, coagulopathy. Okay.
Okay.
So now, for example, if there is problem in the synthetic function, so usually
Albumin will be reduced.
albumin will be low. So what will be the symptom?
Ascites may be there.
Ascites before ascites. Edema.
Edema.
Okay. Because albumin is the related to
Edema.
no, oncotic pressure.
Yes.
Am I right?
Yes.
Or wrong? So when there is low albumin, low oncotic pressure, so there is edema. So this is one of the simple. So and synthetic function, any other symptom, bleeding will be one of them.
Coagulation disorders
Because
will
of
be there. So
because of the coagulation factors. Okay. So usually it may be some bleeding. Okay. And what else? Because of synthetic, I'm just trying to just understand so that you will not forget. What about vitamin K dependent, like vitamin
clotting
K
factors, so they will be
dependent?
still bleeding only.
Okay.
2, 7, 9, 10 clotting
Yes.
factors.
2, 7, 9, and 10. Okay. So if you understand like that, maybe you I'm repeating the things, but if you understand whole of your next of the things which we because if we start in an order or if we understand the thing, you will not forget. For example, now up till now, if you just think about the investigation, you will immediately think about the investigation as well, that you will be doing the liver. If you say liver function tests, for example, so you will be looking at the albumin level. Okay. You will be looking at the A/G ratio. Okay. You will be looking at PT, INR. Okay. So you will be looking at the bilirubin.
Bilirubins. Yes.
Okay. Bilirubin, who is writing on the screen? Please don't do it. By mistake, it is coming. Okay. So joined us. I'm not very good in this physiology at the moment, but what about this color of stool? Okay.
It will be light yellow
clay
colored stools, clay colored.
Clay colored stool in obstructive jaundice.
Obstructive.
Why? Because I think urobilinogen is not coming.
Urobilinogen.
Okay. So it is, but urine become dark. Am I right? So this is what happens. So clay colored stool and dark colored urine. Just correct me if I'm wrong. Okay. And what is like if you just think about obstructive jaundice, so what will be the problem related to obstructive jaundice? That what can happen? One single word, renal failure can occur. What else? If in liver failure, for example.
Sir, why renal failure?
Because of these bile salts.
Okay.
Because of sorry, development of hepatorenal syndrome. Actually, hepatorenal syndrome occurs.
Yes, actually, but that is a diagnosis of exclusion, no? Hepatorenal syndrome.
No, the hepatorenal syndrome occurs in liver failure.
Yes.
Okay. There is no other renal disease. There is no hypotension. There is no hypovolemia. Other than there is no other renal injury. Okay. And purely in the presence of liver failure, renal failure occurs. We will just try. We just maybe again I'm saying that I want you to understand, because everything is written in the books. Okay, maybe even more than what I'm telling you. But if you understand the concept, it will be easier for you not to. You will not forget. Okay, so if you just think about the liver enzymes, ALT, AST, okay, gamma GT, they are because of damage, hepatocellular damage. Am I right?
Yes.
Okay. So gamma GT usually is in alcoholic
Liver disease.
Okay. And ALT, AST is actually non-sick because of any, it can be, but usually in like viral hepatitis, they are occurring. It can occur in other as well. And what about alkaline phosphatase?
That is also
That is actually
non-specific.
non-specific, but it is usually an obstructive cause. Okay. So here if in the exam, they can ask you what are the other causes. So I cannot recall the other causes of increase in alkaline phosphatase, but you should be knowing that.
DIC, HELP syndrome.
HELP syndrome. What else? I'm not
DIC.
sure. HELP syndrome, alkaline phosphatase rate, I don't know. Okay, just
yes, alkaline phosphatase is more than 600 international units. That's one criteria for HELP syndrome.
Okay. 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 So, for example, if there is hemolytic anemia, what occurs?
Yes.
There is increased load of
bilirubin will be high.
So that will be unconjugated.
Yes.
Okay, that will be unconjugated. So it is conjugated with the bile salts.
Bile salts. Yes.
Okay. Another concept which I am weak. What is difference between direct, if someone can explain in a better way, direct bilirubin, indirect bilirubin? Anyone else actually had, the things which we do, direct bilirubin is the bilirubin that is conjugated with glucuronic acid, while indirect bilirubin is non-conjugated to the liver and it attached to the carrier protein. Is it like that? Because this is conjugated, and I thought that concept of direct and indirect is something different. Am I right? Where we measure total bilirubin. Can anyone correct me, please? If someone has correct concept about it. Yes, Nashida. J. Jamil.
Sir, indirect bilirubin is the unconjugated bilirubin.
Okay.
And direct bilirubin is conjugated.
Direct bilirubin is conjugated. So when we say in what is like concept about it? Because we measure total bilirubin.
Yes.
And we measure indirect. Or we cannot measure indirect. We measure either direct or we measure total. Actually, this concept just slipped out of my... Just a second. I think I will just leave it for a while if someone can correct us, or otherwise we will come back to it. Okay. Okay. So we will just hold on for this concept of direct versus indirect bilirubin. I just, it slipped out of me. Okay. So usually one is acute liver failure. Okay. And one is chronic liver failure. Okay. What are common causes of acute liver failure? Common. Viral.
Drugs. Viral hepatitis. Drugs.
Viral hepatitis, paracetamol.
Yes. Isoniazid.
Isoniazid.
Then NSAID is, yeah, paracetamol, you said that.
Paracetamol, not NSAID. Not NSAID, paracetamol. Okay, and what common causes of viral hepatitis among that is hepatitis A and
and
hepatitis
E.
C. And E also. C also can cause fulminant hepatic failure. Okay. So what are common causes of chronic liver disease is viral hepatitis. Okay. What about hemochromatosis? Wilson's disease. Just a second. We'll try not to miss common. Just a second. Okay. So alcohol. Okay. Alcohol, hepatitis B and hepatitis C, non-alcohol fatty liver disease,
Halothane,
hemochromatosis.
sir. Halothane be.
Halothane
Sir,
is,
किसी बारे में halothane use
yes,
होती थी?
yes, in the list you can say halothane, but it's not actually not very common cause. Okay. It is, yes, you are
Yes.
right. And the vascular abnormalities and this. Okay. So just a second. Common causes of acute liver failure like paracetamol. Okay. Viral hepatitis, excessive alcohol intake, and okay, just a second, please. Okay, now if we want to see how much is the severity of liver disease, chronic liver disease to start with, how do we do it? What is the name of that score?
Oh yeah, child-pugh score. Sorry.
Okay.
MELD
So
score.
what are the factors in it?
Child-pugh score has ascites, albumin, bilirubin, then PTINR
Nephropathy,
or prolongation of prothrombin time,
ascites, albumin,
and
INR. Am I right?
yes.
So actually, you can make any mnemonic, but it is I make it with Mr. Bean. Okay. So BEAAN. And is for before it was nutrition. So now it is INR. Okay.
Yes.
So they can ask you the numbers as well, but usually it is either A or B or C. Okay. You can see the values, but the concept I will tell you that, for example, if you see the patient is in A, your aim is not to let the patient go in B. If it is in B, don't let the patient go in C. Try to push it in A. Similarly, if it is C, you will push it to B. And if it is in B, you will push it to A. This is the concept. Okay. And usually what are the correctable things which you can do in ascites? Oh, sorry, in liver failure. Like you can correct the albumin. You can ascitic tab with careful replacement. Okay.
Yes.
And
prevent
what else
the
you can do?
development of infections like spontaneous bacterial peritonitis.
Okay, because it will cause encephalopathy. What else you can do? You can use some lactulose.
The platelet, yeah.
Lactulose. You will do. You can use lactulose. You can do selective this gastrointestinal, because it will cause the bacterial translocation. So neomycin. Okay.
Neomycin, yes.
What else? And then you were saying correction of coagulopathy.
Correction of coagulation factor.
Okay. So you can use some PCC, prothrombin complex concentrate, which is combination of vitamin K dependent factors, or you can give FFPs, or you can give Cryoprecipitate.
Cryoprecipitate.
Okay, so because when in the Viva they will ask you this question, how will you evaluate the patient? So whatever sign symptoms we have discussed up till now, okay, you will be looking at those sign symptoms. You can, in your mind, you can divide it into synthetic function, obstructive function, destructive function, okay? And then you will be looking at what will be the symptoms. We did not discuss about the signs. We will come back to it, okay? But I'm just giving you a concept because they have very difficult names. We will just come to that shortly. But usually in the exam, in the table Viva, when they are asking you, okay, so the more important thing is that you will say that I will evaluate the severity of liver disease on the basis of history, examination, and investigation, and I will quantify according to Child-Pugh score, okay? Because as high is the Child-Pugh score, the higher will be mortality and morbidity.
Yes.
Okay, so in addition to whatever we have discussed up till now, you can say you can correct the heart failure, okay, because these patients are overloaded. They have overloaded circulation, because so you can use some spironolactone, okay, and even furosemide.
Furosemide.
So because we will be just entering into the pathophysiology and what happens in it, but actually this is from where they usually start the Viva, okay? So that's why I told these things first, okay? Now, for example, if we just look into, because this is the whole, whatever is being discussed, this is the pearl of what you should be knowing, okay? So now, for example, if you just go one by one, so if we just, what about portal hypertension? How portal hypertension occurs?
Hello.
Yes. What is the reason for portal hypertension?
Because of liver cirrhosis.
So what happens that there is increased resistance?
Yes.
What else? So what happens at Porto? Signs of Porto, systemic shunts. Usually,
Shunts. Yes.
what are they? Esophageal, lower esophagus,
Yes.
rectum.
Rectal. Yes.
Okay.
Umbilical.
And
Peri-umbilical.
so what happens in spider nevi?
ما شاء الله ما شاء الله ما شاء الله.
Okay. So spider nevi is because of it. It is in the abdomen. Okay. What else? Portosystemic shunt can lead to upper.
Yeah, there will be upper GI bleed, lower GI
upper
bleed.
GI bleed, which is a medical emergency. Okay.
Yes.
What to do with it? Airway, breathing, circulation.
Breathing, circulation.
And
yes.
you will be taking the IV lines. IV lines. Okay. You will be activating the multidisciplinary team. Okay. You will be going towards one will be medical management. Okay. Then gastroenterology, medical management by this
bleeding, yes.
octreotide.
Octreotide, yes.
And it may be banding. And there is one Sankstein Blackmore tube. Okay. So you will be stressing a lot on ABC because maybe you need to give vitamin K later on, but because it will not be effective immediately. And you will be activating in multidisciplinary team. You will be activating the ICU. You will be activating the gastroenterologist. You will be activating the blood bank. Okay, for blood and blood products. Blood and blood products. Okay. Because this when they reach, if they have in the scenario, they can ask you these things. So banding, this medical treatment with octreotide and Sankstein Blackmore tube, which is with the pressure. Okay. So this is just an outlook of what happens here. And rest of the things we have, number of things we have discussed. So now what is the effect in the cardiovascular system?
There is cardiac overload features.
Overloaded state. Okay.
Yes.
So volume overload is because of activation of renin, angiotensin, aldosterone system.
Yeah.
So this is actually also cause of ascites. Okay. Ascites is also what there are. If I can recall, there were two theories of development of ascites. One was because of low albumin. Okay. And one is because of like this one volume overload. Okay.
Okay.
There are two things. One thing is that there is more volume, and the other thing is that force which is keeping the fluid in the intravascular space is decreased. So it will be leading to, and whenever there is more aldosterone, there is increase in
sodium and water retention
and decrease in potassium. Okay, that's why if you remember, I just told that they are taking this aldosterone antagonist.
Yes, spironolactone.
Spironolactone. And actually this is actual the sodium becomes, total body sodium is increased, but actually there is hyponatremia
due to dilution.
Okay.
Yes.
So this is the, and then in addition to that, there will be AV shuntings. Okay. So AV shunting that occurs. What about this Palmer erythema? Okay. And when it occurs in the lungs, it is causing
hepatopulmonary
syndrome. Okay. And due to these AV shuntings, there is a terminology which is called as platypnea, orthodeoxia. Have you heard about it? There is when the patient lie flat. Just a second. Actually, dyspnea improves. Okay. And there is, because there is shunting, AV shunting. There is, or this one, when the patient is lying, this one lying, sitting, there is deoxia. I don't remember the reason. We will just try to search in the text. Just a second. Can anyone explain how this hepatopulmonary syndrome occurs? Just a second, please. Okay.
Sir, because of decreased metabolism of pulmonary vasodilators, there will be pulmonary vasodilatation. So there is basically imbalance between vasoconstrictors and vasodilators. That will lead to the right to left shunt.
It is right to left shunt.
Yes.
Okay. Okay. Actually, this I forgot. Okay. And you know, in the exam, till the time they don't ask you, just stop at AV shuntings. Okay. If they ask you to explain and you are sure, I forgot. I don't have very good concept about it. Just can you repeat it again, please? Because of excessive vasodilators, there is a vasodilatation and there is right to left shunt. Am I right?
Hello, sir. Can you hear me?
Yes, now I can hear you, please.
Yes, because of impaired hepatic function, there is decreased metabolism of pulmonary vasodilators.
Okay.
So that will lead to the imbalance between vasodilators and vasoconstrictors.
Mm-hmm.
It will lead to the pulmonary vasodilatation.
Mm-hmm.
And this pulmonary vasodilatation will create a state which is called right to left intrapulmonary shunt.
Okay.
Because as we usually heard, like there is intrapulmonary shunt that is leading to hypoxia. So when there will be right to left shunt, so it will be the just like the state in any congenital right to left heart shunt, congenital heart anomaly.
Mm-hmm.
Decrease oxygenation, more hypoxia. And this is
Okay,
hepatopulmonary
because
syndrome.
actually this is very complicated. There is terminology portopulmonary hypertension. What is it? Okay, very occasionally a patient with portal hypertension will be found to have pulmonary hypertension. Okay, with increased pulmonary
Yes,
vascular
sir.
resistance and normally pulmonary capillary wedge pressure. Don't actually you see, because I am not very comfortable in it, I just have a look later on. I will share the article because the agenda for us is very big. I will try to cover as much as possible. Okay, so just remember this thing that usually there is shunting. Okay, and there is vasodilatation which is causing this orthodeoxia, but it can also lead to pulmonary hypertension in isolated patients. Okay, and because of overload state and in ascites there is a splinting, FRC is reduced, so there is this one shunting. Okay, and patient will have hypoxia and atelectasis. Okay, cardiovascular system, there is high cardiac output and low SVR. Okay, low SVR,
Okay.
so it is high cardiac failure. Okay,
Mm.
when there is of course the cardiomyopathy also develop. So this is alcoholic cardiomyopathy. Okay.
Yes.
So okay, so portal hypertension we have already discussed. Can you explain about something more about how portal hypertension develop? One is the cirrhosis, so there is increased resistance. Am I right?
Yes.
Anything else? Any other reason for it?
Mm.
Okay. So to treat portal hypertension, beta blocker is used, octreotide is used. Okay, and they for also because ascites will be resulting, so salt and water restriction, and as I told you that they need to this like drain. Okay, and other thing will be that you have to replace the fluid accordingly, because otherwise patient will go into
Yes. Shock and
shock.
cardiovascular collapse.
Yes. So encephalopathy, regarding encephalopathy, we said that you have to prevent hepatic encephalopathy because with the infection, and if GIT hemorrhage occurs, fluid electrolyte imbalance occur, because if sodium balance is there, it will precipitate encephalopathy. During the anesthesia, if you give some more sedative agents, it will cause encephalopathy. Okay. So it is great. There are gradings for encephalopathy, but usually
Yes. 4 grades.
have to avoid the factors: infection, as I discussed, lactulose, neomycin, okay, and antibiotics, and avoidance of the factors like hypotension and everything. Okay. Also to avoid excessive protein. Okay.
Yes.
Okay. Hematological we have discussed. Okay, so we will just shortly see into the hepatorenal syndrome just for a while. We have, I think, malaise, weight loss, dyspepsia. These are the general sign symptoms. Just a second, please. I discuss about this optimization. Okay.
Mm.
Okay, so actually when I was talking about this child pug score, two more score you should be knowing about it. One is King's College criteria for acute liver failure, and usually it is used for paracetamol poisoning. Okay.
Okay.
And this MELD and PELD, model for end stage liver disease. This is also for liver transplant, and PELD is for pediatric.
Pediatric.
You should, if you don't remember the exact, but you can just, because you will find a formulas, but if you forget the formulas, you can just only have the parameters like bilirubin, creatinine, and INR. Okay.
Mm.
So we discuss about this etiologies. Okay, so what happened in decompensated liver cirrhosis? Where is Memuna? Memuna, would you like to say something?
Hello, sir. Hello.
Yes.
Sorry, I just I'm also doing some home stuff, domestic
No problem.
things.
So
Okay,
actually,
we were, yeah.
if you want to talk about some words about hepatorenal syndrome.
Hepatorenal syndrome basically is I will explain in the same way that there is a decreased peripheral vascular resistance, which will lead to increase. Basically, the renal vascular resistance increases. So it is just like the pre-renal renal failure. Initially, when there will be decreased peripheral resistance, renal angiotensin system will be activated, and we know that have the effect of vasoconstrictive effect of renal vessels, hypoperfusion of the kidneys, that will lead to the oliguria. And side by side there is hyperdynamic circulation. So kidney will try to conserve the sodium, which will lead to low urinary sodium. And although because of the hypervolemic state, there will be serum hyponatremia. So chronic hypoperfusion of the kidneys will lead to the renal disease.
Yes,
Renal failure.
the main simple word is that whatever pathology is going, we will label it hepatorenal syndrome when there is absence of any other factor or any other renal disease. Okay, there will be no primary renal disease, and there is renal failure, uh, which occurs in
Yes,
this.
and there will be absence of shock as well.
Okay, like usually, because they mention here that there may be reason of renal failure in cirrhotic patients. That is what you were telling, ATN and pre-renal. Okay, so but when this pathology is a little complex. Okay, and you can have a look. They will not ask you in so much detail. That's what you were telling. Okay, so there is two dilators. Okay, and then effective hypovolemia. Okay, leading to intense renal vasoconstriction. When there is excessive renin-angiotensin activation, there will be renal vasoconstriction. ADH is activated, giving rise to hyponatremia. Okay, and is associated with cirrhosis. In extreme instances, acute cortical necrosis due to renal artery vasoconstriction can occur. The cardiac output in hepatorenal syndrome was traditionally felt to be high, but recent thinking puts cardiac dysfunction on a background of cirrhosis as the major important trigger for hepatorenal syndrome. this so-called serotic cardiomyopathy, which we discussed, okay, is distinct from alcoholic and ischemic cardiomyopathy, both common in this patient group. Okay, vasoconstriction is also observed to occur in the cerebral arterial circulation, which combines with hepatic encephalopathy to depress consciousness. Actually, you don't need to know so much details, but if they ask you, you can explain that there is complex pathology going on in liver failure. The effective circulatory volume is decreased, and there is overloaded state. Okay, and there is decrease in renal perfusion, and this renal failure occurs. Okay. Variceal bleed. Okay. Okay, we have discussed about these investigations. Some of them, I think we did not see it will be the individual cause, alpha-1 antitrypsin deficiency and ceruloplasmin in Wilson's disease. Okay.
Okay.
How to monitor ascites? How to monitor ascites? With the abdominal girth. Okay.
Yes.
And body weight. Abdominal girth and body weight. Okay. This is what more model for end stage renal disease, spontaneous bacterial peritonitis. Just a second. Okay, this was Child-Pugh score, which I explained to you. Okay, renal dysfunction, encephalopathy.
Mr. Bean is mnemonic.
Yes, it is easier to remember. Okay. So
Yes, sir,
another
because
thing.
I could never ever keep it in mind. So after this Bean mnemonic, it is very easy.
Okay, thank you.
I
Okay, so
remember like ABCCP.
you know,
It's
it's up
like
to you. It's just like
yes.
democracy. You can make any mnemonic, okay? Because some mnemonic are so sometimes so odd that even we cannot share to anyone. Am I right?
Yes.
This is a funny mnemonic, so I told, and I think you will not forget.
Yeah, it's good.
So in addition to all the electrolyte imbalances, I forgot to tell you about this hypoglycemia, which can occur because of loss of glycogen stores. Okay.
Okay.
So even in whether it is acute renal failure, liver failure, or chronic liver failure, ultimate treatment will be liver transplant. Okay.
Liver transplant.
So usually if they go towards transplant, you can just keep in mind, especially if you are appearing in EDAC, I think they can ask you this MELD and PELD. And okay, so I'm just trying to see if anything important I did not tell. Yes. What about like, for example, if you have a liver patient, what will be the anesthetic challenges? Okay, well, now we come to where we have covered some of the pathology part. So now we will see how will you quantify, or how will you chalk out the risk factors. Yes, Nashida, please, one by one. Try to think about the more important than less important. Okay.
So definitely variceal bleed important.
Variceal bleed during what?
During intubation or
okay, so
yes,
it will be, you
or
can say aspiration.
There is hypertension. Yeah, there will be
aspiration risk. Okay.
Okay.
If you give induction, would you like to give rapid sequence induction?
Yes,
or
rapid sequence.
modified rapid sequence induction, or elective with that long acting like atracurium? What will you do?
Sir, I would give modified rapid sequence.
actually you can, if in the oral part, you can say it's a tricky patient. Nothing is safe and you have to make an individualized plan. Okay. You have to be ready for any hemodynamic sequelae. So with induction, you can say that in addition to this standard 1 and standard 2 monitoring, I would like to have arterial line.
Yes.
Before starting. Okay.
Okay.
So that you have better control on the hemodynamics. Okay. What about use of suxamethonium? Is there any problem? You can use it or no?
Action can be prolonged.
Yes, its effect can be prolonged. Why?
Prolonged.
Pseudo?
Stress less.
Okay, so this is one thing. If you give, for example, you said rocuronium with modified rapid sequence reduction, what are the problems with it? You should have Sugammadex.
Sugammadex.
Because rocuronium is metabolized by liver and excreted through kidneys and bile. Both of them. It is excreted through kidney and bile. So actually, if you don't have Sugammadex, then you might have problem. Okay. So this is what about induction agent? Like the first concern will be aspiration risk. So then induction medication. What would you like to give, or what you would not like to give? You can give propofol. You can give
etomidate.
Okay, why would you like to give etomidate?
Because it's more cardio-stable.
Cardio-stable, very good. But what are the problems associated with it?
The depth of anesthesia will be less with etomidate.
Myoclonus, yes. Adrenal suppression. So this patient is already prone to infections. Okay, so adrenal suppression can have a problem. Okay, so you can make a cocktail with the. What about ketamine? Can you give ketamine?
I could be right. Yes, if the patient is hypotensive, ketamine will be safer, I think.
Would you like to give etomidate in such patient or ketamine?
Really hypotensive patient, I would go for ketamine, sir.
Okay. So we discuss about monitoring. We discuss about induction. What about ascites? Will it have a problem? It will be reducing the FRC.
Yes.
So you have to pre-oxygenate.
Pre-oxygenate.
Okay.
And it will also make the patient more prone for aspiration.
Yes, aspiration, we discussed that aspiration. And another thing is that if you have an abdominal surgery and suddenly when they open the abdomen, suddenly there can be hypotension. Okay? And because the circulation is already overloaded, so crystalloids, you cannot give very liberal. Okay. So maybe you need to give colloids like albumin. Okay. So this can be a serious problem at the time of induction in reduction FRC. And then when you open it, then it can be a problem. Okay. And there is a reshuffling of the fluid. And so you have to look into it. Okay. So what are other challenges? I forgot to mention that you should have an HDU or ICU arranged for it. And another thing is that, would you like to do any elective case? No.
No, only emergency cases.
Emergency cases, and the same thing that you will be targeting, pushing the C to B and B to A. Okay? You will be optimizing the patient. And what about the analgesia? I'm sorry?
Yeah, same.
Okay. So what about analgesia? Is it safe to give paracetamol?
No.
Is it contraindicated, or you can reduce the dose?
Can reduce the dose.
Can reduce the
Okay.
dose, I guess.
Okay.
Fentanyl can be given.
At this moment, if I ask you, what is the reason for paracetamol poisoning? How paracetamol poisoning occurs? Actually, it is not that paracetamol is hepatotoxic.
Glutathione depletion.
Yes, glucose, like for example, that when there is some metabolite, it is usually that metabolite is conjugated with glutathione to make it non-toxic. Okay. When this liver is not functioning well, that this conjugation will be a problem. Okay. So when this conjugation will be a problem, then this will occur. So you remember in this question may be asked in MCQs. Okay. And also you should be knowing that itself paracetamol is not damaging the kidney, the liver. It is the problem in the, like you can say, dumping of the metabolite. Okay. So this is the concept. So actually you can give in reduced dose, or you can say with caution. Okay. Because NSAIDs you cannot give. Paracetamol, for example, you don't give. Then opioids will be a problem. So, and if you give local anesthetic, is there any problem with local anesthetics?
Do you mean by like epidural?
No, any by any source. If you are giving, for example, bupivacaine, okay, from where it is
Their
metabolized?
volume of distribution will be, yes, they are metabolized by the liver.
No, bupivacaine or lidocaine, both of them are metabolized in liver.
Liver, yes.
Okay, so even their doses has to be reduced. Okay. So actually, so that's why you among the opioids, what is the best one?
Fentanyl.
No,
Fentanyl.
No. Remifentanil. Why?
Shortest acting.
Not, it is not the reason. It is metabolized in the by
Non-specific esterases.
esterases. Okay. So this is the best one. Otherwise, fentanyl. Why fentanyl is not a big problem, or the sufentanil or L-fentanyl? Because their circulation time is less. They are very high.
They have no metabolites.
No. Who said this? Who said this? I will not hit you. Who said it, by the way? I couldn't see.
Sir, I said.
Okay. Actually, they have less circulatory time. They are highly lipid soluble. So they don't remain in circulation for a longer time. Okay. But their metabolism is by liver. And their elimination half-life is increased. Okay. So you can use them, but with caution. Morphine.
Cannot be used because it forms morphine 6-glucouronide.
Yes. So it has active metabolites. So you will not use morphine. Okay. So NSAIDs, it's not better not to use.
Not use. Yeah, it will precipitate bleeding also.
What about dexmedetomidine? Okay.
Yes,
you can
be used.
Can be used.
Yes. Dexmedetomidine you will use. Okay.
Yes.
As I told you that lidocaine is being used as a IV analgesic, but you will reduce the dose. Okay. Similarly, what about central nuclear block? Can you use epidural?
Depending on this, the coagulation will be abnormal in these patients. It is generally not given.
What is the smart answer for it? You will always do the risk versus benefit. Okay. It's never safe to give. It's never safe But for example, if you have correct the coagulopathy, and then there is compelling indication.
Okay.
In the exam, it is better you say that it's not very safe idea, because there will be chances of epidural hematoma
Hematomas.
and abscess, both of them.
Okay.
If you compare between spinal versus epidural, what is the problem? Because epidural needle is big, so there are
Bigger,
more
yeah.
chances of hematoma. Okay. And
Yes.
because the patient is hemodynamically unstable, so spinal will have this problem.
Oh,
Okay.
yes. Okay.
What about peripheral nerve blocks? And what about compartment blocks?
Again, in that,
What?
we will have to use large amounts of local anesthetics. So,
Ultrasound guided and superficial blocks. Okay. Like, for
okay.
example, it's not a good idea to do infraclavicular. Supraclavicular is relatively superficial. You don't need to poke too deep. But again, in the exam, a smart answer is that this one, which I said.
Risk versus
This is
benefit.
be like a politician. Okay. Because if you use a closed-ended sentence, no, you will not be able to come back. Okay. So if you use this word that I will be outweighing the risk versus benefit, and then I will chalk a plan. Okay. What about
So can
compartment plan?
I
Yes. Yes, please.
So because if we are doing suppose we are doing an infraclavicular block or something, for all these blocks, coagulopathy is a contraindication.
Yes, of course.
And
of course.
yeah, so these people, like these patients, they will be having might be having coagulopathy, and also because these drugs are metabolized in the liver,
Okay.
there is a risk of toxicity also.
Yes.
So
So that's why,
is it
it's like a complex situation. Okay. So because similar thing occurs in CRF, that there is a platelet dysfunction as well. Okay. So what happens then that if you, for example, if you have to make the patient for AV fistula, for example. Okay.
Yes, okay.
So like and especially in younger childs. Okay. So what you will do, you have to give something. You can give GA, but if you outweigh risk versus benefit, maybe if you just give block and do a little bit of sedation, you can do it. Okay. So, like similar. Actually, there is no safe. If you say rapid sequence induction for and you don't tell that what are the problems associated with rapid sequence induction, the examiner may catch you. We did not actually, I missed that time. What is the best muscle relaxant in these patients? Cis-atracurium.
Cis-atracurium.
Then atracurium. Panchronium should not be given because it is purely
and liver is the metabolite.
Vichronium and rochronium are the same. Okay. So among the analgesia plan, you have to make out a plan. For example, if I give you a scenario, you have if you have a patient with the CLD, okay, ascites, and this old man now has developed obstructed inguinal hernia.
Okay.
Okay. So they can do it under laparoscopic or open.
Okay.
So if you want to give, for example, analgesia, what option will you have? Can you give tab block?
No. No, because he has ascites. So
Okay. So how will you give analgesia? Actually, it's such a complicated thing that actually while they are closing it, they are coming the ports. Actually, the surgeon can give the tab block.
Tab block.
And actually,
Okay.
surgeons are giving through laparoscope under vision.
Yes.
Okay, so this is one of the option.
Okay.
And similarly, like as we discussed that when we will induce the patient can have sudden hypotension. So you have to take care about it. Okay. The same concerns at intubation will be at extubation. Okay.
Okay.
And another, what else is there? You have to take care of hypoglycemia, hypokalemia, hyponatremia.
Hyponatremia.
Okay. So what you like to do some point of care testing this patient? What point of care testing you can do? You can do ABGs.
Like ABG.
Blood sugar. INR. INR is also there in bedside machine.
Thromboelastography.
Thromboelastography. Okay. Or rotum.
Rotum.
Okay. So in the monitoring, we told about invasive blood pressure monitoring. In addition to that, you can do cardiac output monitoring. Cardiac output monitoring. And in the invasive blood pressure monitoring, you can do the stroke volume variation. Okay.
Yes.
And what about ultrasound to see vena cable?
Vena cable diameters.
Compressibility. Not diameter, compressibility. Okay.
Okay.
So because you cannot give too much fluid, so you can monitor your fluid resuscitation through it. Okay. And urine output. Okay. What about TIVA versus inhalational? Which inhalational agent will be the best? Desflurane.
Desflurane.
Then
SIVO.
SIVO or ISO.
ISO.
Then CO. It is a rule of 0.02.
0.2.
Just a second. 0.02, 0.2 to 20. Okay. So the least metabolism occurs with desflurane, then isoflurane. So you can make it with dish.
Okay.
Okay. What about TIVA? Yes.
I think in TIVA, the volume of distribution will be greatly, changed in these patients.
What about with remifentanil and propofol? And especially target control infusion. Okay. Okay. Like for example, in some scenario, I give you example. For example, this patient with the liver failure is for ERCP.
Okay.
Okay. And actually these patients also come post liver transplant.
Yes.
Okay. So they come for ERCP. So they are a tricky patients. Okay. So in these patients, you can have with dexmedetomidine. Okay. Can you do it without intubation or no? Can you do it in deep sedation or conscious sedation?
Deep sedation, yes.
Risk of aspiration or no?
There is a risk for aspiration.
Okay, and they are doing it in semi-prone. So can you control the airway in that position?
No.
Again, I will keep on recalling you that try to have risk versus benefit. Okay. Always use the word discuss with the surgeon in your Viva. If you see my previous discussions, you will find a topic how to prepare for the Viva. So in that, there are three components. One are patient demographic factors. Okay. Other is the disease related. And the other third is surgery related. And the last is anesthesia related. All these things are anesthesia related, but demographic means the age, sex, height, weight, occupation, personal history, personal habits. Okay. So things related to personal history of the patient, and disease related, the disease which we are discussing. Okay. It can be one, it can be more than one. Then surgery, in surgery, there is urgency, risk, in CN, any critical step. Okay.
Okay.
And bleeding versus thrombosis risk. Duration. In CN, you will, according to NCN, you will have analgesia plan. Okay.
Yes.
Urgency means whether it is can be delayed or no. So all these things, what approach surgeon is doing. Okay. Any specific positioning. So this is a default plan. Understand? So now if they have given you a scenario of a 50 years old male or versus 55, for example, 55-year-old female versus 55 years old female versus 55 years old male. So what will be the difference? That 55 years old female might have post-menopausal syndrome.
Yes.
Okay. And this patient might be on HRT. Okay. So this information will lead to you for steroid replacement, maybe if it is higher dose, and also hyperglycemia. Just a second, please.
And they are also more prone for developing DVT.
Exactly. Hyperglycemia, DVT, steroid replacement. You see, so the demographic data told you something. If you have a patient with high BMI, what will you do? You will be preparing for, we discussed obesity few days ago. So you can have a look on it. So obesity related, so you will be ruling out OSA. You are expecting the logistics issue and everything. Okay. So this is how you will be approaching any scenario. And the disease related will be, what is the main pathogenesis? Main problem. What is the main, some disease will be systemic or some disease will be multisystemic. Okay. And you will be opening your shop, that you will be seeing that any effect on induction, airway, monitoring, okay, muscle relaxant, okay, and fluid, analgesia, okay, PUNV, aspiration. These are the basic steps of anesthesia. So whatever disease you are reading, just try to have a look on CVS, CNS. Your medicines are metabolized by liver and excreted through kidney. Am I right?
Yes.
And all is your management is, so you will be looking, you rather than reading that disease in detail, try to fit it in this format. Okay. I have made this. Just a second. This is a file with name of anesthesia plan, and whatever I told you is written here. So you can have a look on it. So it will be easier for you to understand what I'm saying. Analgesia plan, religious anesthesia plan, induction plan, maintenance plan, fluid management, any related thing related to blood loss, stress response, and everything. Okay.
Okay, sir.
So, okay. So that's how you will be targeting. Unfortunately, when we are reading the books, it's not written in this format. And the exam, they are asking you in this format. Whether it is written, whether it is MCQs, whether it is Viva. Okay. So actually, I just try to make you understand what are the do's and don'ts. Okay. So you will be seeing the same things which we have discussed. Okay. Any questions? Yes, in the investigations, ECG, you will find some things. Echo, if there is, because will overloaded circulation will have some regurgitant lesions. If there is cardiomyopathy or, for example, heart, like there may be coexisting ischemic heart disease or anything. So you will be finding all this. Chest X-ray, you will find the findings of overloaded lungs. Okay, there may be pleural effusions or there may be pericardial effusions. Okay. Pulmonary function test also to actually, low albumin is a isolated pulmonary risk factor. In any patient, if you find to have low albumin, it's a risk factor for postoperative pulmonary sequelae. Okay. So similarly, in this patient, you can evaluate any identifiable things and to correct them, optimize them. Okay. So preoperative, we have discussed everything. I'm just having electrolyte, volume status, coagulation, infection status, pre-optimization with vitamin K, FFPs, okay, decompression, desmopressin, platelet transfusion, tag use. I have discussed almost, I have tried to cover as much as possible. Gastric emptying, release, sedative pre-medication should be avoided or used with caution, okay? Infection, electrolyte dysfunction, you can have an ABGs, okay? Monitoring, cardiac output monitoring, CVP. But again, CVP, you will try to have an excess where, what will be the indication for CVP actually? Is it for only volume status? No.
No,
If
actually to give drugs also, vasopressors.
If you want to have vasopressors, then
Yes.
otherwise for volume status, you can see it by arterial line and cardiac output monitor. Okay. Okay. So warming of IV fluids, risk of infection. Yes. And one important thing I forgot to tell is occupational protection. Okay. Because these patients might have hepatitis B, hepatitis C, or any viral infection. So you have to do the barrier precaution, wearing gloves, taking care while taking IV lines. Okay. Taking care of secretions. And okay, N-acetylcysteine is for protection of liver. Okay. Propofol, thiopentone. If the patient is alcoholic, there may be sign symptoms related to withdrawal. Okay.
And bronchitis and encephalopathy maybe
yes,
there.
in monitoring, I forgot to mention this. Monitoring of neuromuscular blockade. One is encephalopathy also related to thiamine deficiency. Okay.
Yes.
So opioids, we discussed fentanyl in low dose is a better option as it is renally excreted. Okay. And another thing is related to usually the acidic drugs, they bind to albumin.
Albumin. Yes.
Okay. Okay. Our anesthesia drugs usually are basic.
Basic, yes.
But anyways, if there is low proteins, there may be increased free drug. Okay. If there is low, slow metabolism, there will be a reduction in the requirement of maintenance. But initial, because of high volume of distribution, maybe initial doses may be required more, but subsequent doses will be decreased. But if there is if increase at the same time, there may be increase free drug. So you have to carefully decide. Okay. And there are some concerns related to calcium as well. Okay.
Okay.
Okay. So any questions, please? Yes, I hope you understand, because I just try to give you an insight about how to uh, look into liver, because some things need more details, but I just try to give you an insight about if you find a liver disease patient in exam, whether in long case, you have to evaluate all the systems, because in some exam patterns, they are giving the patient to evaluate. So you will be evaluating from head to toe, symptoms, signs, correlating, then stratifying where the patient falls, what surgery patient is going for, how much you can optimize, am I right? How much are the cardiac risk factors, renal risk factors, pulmonary risk factor, aspiration risk factors, airway risk factors, positioning related problems. So you have to uh, make plans for everything. Okay.
Yes.
So I think we will stop here, and inshallah tomorrow I will try renal system. These articles are there in the link. I will share the link. Okay.
Okay.
Dr. Suhail, you did not comment anything. Yes, Dr. Suhail, can you hear? Okay, Nashida.
Yes, sir, मैं
So
सुन रहा हूँ, sir.
yes, okay. So Nashida, you can
Sir,
find.
sir, मैं actually, sir, मैं एक तो update. I was not updated regarding this topic, but I was just listening. Few queries I wanted to ask regarding
Okay,
analgesia, sir.
okay, fine.
We can give remifentanil, all these things, but what about ketamine in a analgesic dose? Can we give it
Actually, the
low dose?
metabolism will be slowed, but you can give.
Okay.
Because ketamine is like as a dissociative anesthesia. It does not cause
Yes, sir.
respiratory depression too much. Okay.
Okay.
So it's a good choice. Actually, nothing is 100% safe. You have to just, among the evils, you have to choose the less evil. Okay.
Okay, sir.
Anything else?
Okay.
Sir, in this case, when we're keeping ready the vasopressors, is there anything like the best vasopressor of choice for this, for
Okay.
liver case?
Okay, just tell me one thing. What is the main hemodynamic problem in it? Sorry, SVR is decrease. So
Decreased, yes.
norepinephrine. Okay. And for example, if you have some like cardiomyopathy, and now ejection fraction is decreased, so then in
Dobutin.
that case you can have low dose epinephrine in
Okay.
addition to norepinephrine. Okay. If,
Sir,
for example, yes.
Sir, excuse me, one more question regarding pre-medication.
Okay.
I think benzodiazepine, I can give in a low dose, or what should I do?
In the exam, better say avoided. Okay. Again,
Okay, sir.
I have
Okay.
told you for oral part, risk versus benefit.
Okay, sir. Thank you.
Okay. If you are thinking about written MCQs, they will give you a some hint. Okay. But usually it's not 100% contraindicated, but you have to use very cautiously. Okay.
Okay, sir.
Because if you give overdose, there will be chances of patient going in encephalopathy. Okay.
Okay, sir. Okay, sir.
Because
Thank you, sir.
our principle is that you give the medicine which has less metabolism.
Right,
Okay.
sir. Sir, sorry, you were talking about epinephrine and norepinephrine, sir, in the last.
Yes. So norepinephrine is good for low SVR. Okay. Because the main pathology is SVR is decreased. So you want alpha agonist is a good choice. If you have some, you need some inotropic support. Okay. So and then you can add epinephrine with it. Okay.
Okay, sir.
So milrinone in case of right ventricular failure, but it cause decrease in SVR further. So it's not used milrinone.
Mm.
Okay.
Yes, sir. Even in ICU, we are using milrinone, we have to add adrenaline if the
Yes.
patient is in hypotension.
So
Yes.
you know about it. So another
Mm.
actually in modern anesthesia, usually there is no indication for dopa and dobuta, which is the most common medication in the past. Okay.
Oh, okay,
Because
sir.
in this scenario, if you give dobutamine, it will cause decrease in SVR
SVR,
because it
yes.
is beta 1, beta 2
Mm.
agonist. So it will cause beta 2 mediated vasodilatation.
So dilatation. Yes.
All the effects which you are getting with dopamine, you can get with low dose epinephrine. So actually, unfortunately, the medications which we were using in the past have no, in last, I think, 11 years since I'm in Saudi Arabia, I've hardly, even 2 years in cardiac anesthesia, I hardly used dopa, which were our darlings in Pakistan. Okay.
Mm.
So people are afraid of epinephrine and norepinephrine, though they are the best medication. Okay.
Okay, sir.
So
Thank
actually we try to discuss everything. You can use ranitidine and PPIs. PPIs actually are metabolized by, what about PPIs? Are they enzyme inhibitors or enzyme inducers?
Cimetidine is an inducer.
No. This is H2 receptor. PPI is inhibitor.
Inhibitors.
Okay, Nashida, I hope you understand something. And thanks a lot, all
Yes.
of you.
Thank you so much.
So tomorrow I will try to have similar quick review of illnesses. It's not good thing, Dr. Umera, your mic is not mute. In the YouTube channel, you can find the previous discussions on liver. Just a second, I will just show you. In the morning, actually, I forward it in the group as well. Okay. You are in the WhatsApp group as well, Nashida?
No, sir. I am there only in this group.
Which group?
The EDAC group.
Okay.
Fast track.
So, okay. No problem. So,
You have a different group, sir?
yes, you can message me You can message me. I
Oh.
can use, I can add there as well. But usually these days I am forwarding everything over there as well. Okay. So in the
Okay.
previous discussions, because I have done since last 6-7 months, I am doing regularly. So you see, you will find some previous discussion about this one also did, I did it, and this one also did it. Okay. Because they will give
Okay.
you a scenario. So it will be a one patient related problems, one disease related problem, and there will be one surgery. So the scenario comes like that. Okay.
Okay. Thank you so much.
Okay. Thank you. And bye bye.